So good evening, everyone. Welcome to the ACP Problem Solving in Oncology webinar series. I'm Rachel Broadbent, and I'm pleased to be able to welcome you to our webinar series, which has been set up to provide equal educational opportunities to trainees and fellows in medical and clinical oncology across the UK. Webinars will be held on the third Tuesday of each month from 6 till 7:30, with expert-led presentations and case discussions focused on a particular tumour type or topic. Today's session will cover lymphoma and stem cell transplantation, and we have two presentations from our expert panelists on the principles of stem cell transplantation and diffuse large B-cell lymphoma. The educational content of these meetings are entirely non-promotional, but we're proud to have the webinar series sponsored by Pfizer Limited, world-renowned leader in oncology pharmaceuticals, and more information is available on their websites. Just to remind you, our online educational platform delivered by EBN Health is live. Webinar sessions are recorded and made available to all ACP members via this website. In addition, the website offers access to the ACP's Problem Solving in Oncology book series. To access this, go to acplibrary.ebnhealth.com. So it's with great pleasure that I introduce our first speaker of the evening, Dr. Beth Phillips. Dr. Phillips is a clinical senior lecturer at the University of Manchester and honorary consultant haematologist working in the lymphoma group at the Christie Hospital. She completed haematology training at the University College Hospital London, where she later worked in the lymphoma clinical trials team. She undertook postgraduate research at King's College London, examining the role of the immune system in follicular lymphoma. So this evening, Dr. Phillips will present on the principles and application of stem cell transplantation. Over to you, Dr. Phillips. You should be able to share your screen.
Thank you very much for the invite, and I hope everyone listening finds this helpful and interesting. So I'm going to be talking about the principles of stem cell transplant, and because it's my area of speciality, I will be focusing principally on lymphoma. Rachel has outlined my current role with the Christie Hospital and University of Manchester. I'm a consultant haematologist, but I currently work within the medical oncology team at the Christie. So when I was putting together this talk, I kind of thought, well, what is relevant for medical oncology trainees? What is the role of transplant, and what might be useful from this presentation? So, firstly, I think it's important to know what the indications are and why we use transplant. And I'll talk quite broadly about the mechanism of action. But my current role, so I trained for 8 years in London, and I was heavily involved with delivering stem cell transplant at that point. But I'm aware that many of you won't be involved with direct delivery of stem cell transplant or cellular therapies. But having moved into a medical oncology setting now, what I'm most involved with is deciding who goes for transplant and patient selection, and also the care of patients pre and post-transplant. And I think this is one of the most important areas to focus on for the medical oncologist. In terms of going back to indications for stem cell transplant, again, I'll be focusing on lymphoma, but I'm aware that stem cell transplant is also relevant for sarcoma, although I won't be presenting the evidence for transplanting sarcoma today, and also that it's been trialled in other areas in medical oncology, and the principles that I'll discuss today will hopefully be relevant to other aspects of medical oncology too. And at the end, I will outline some of the future directions for cellular therapy in lymphoma. So a slight deviation to start with, and I thought I'd introduce you to the process of transplant regulation and oversight. And if you can bear with me on this, there is a point to this. So as you're aware, that transplant traditionally has been the preserve of haematologists, and that's largely because most of the indications for stem cell transplant to date have been haematological, but they are growing. Oversight is managed by a body called JACE, the Joint Accreditation Committee of the ISCT Europe and the European Group for Blood and Marrow Transplantation. And so JACE has a key role in regulation and oversight of all cellular therapies, including stem cell transplant and CAR-T. And they outline the requirements for transplant services in terms of standards for collection and administration of cellular therapies, quality management, but crucially here, they dictate the requirements for physician oversight. I'll come back to that in the next slide. They also have a broader role in collecting data and research across Europe, and there have been quite a few important publications about transplant outcomes from JC and EBMT. But this is the point this is the point that I'm hoping to make here, that JC dictates the requirements to be an attending cellular therapy physician. And it's not just haematologists that can get involved with this. To be a qualified cellular therapy physician, you can be a board certified medical oncologist. All you need to be a cellular therapy physician is to have had a minimum of 1 year supervised training in the aspects of transplant and cellular therapy that are relevant to your care. So that could include autologous, allergenic, transplant, or immune effector cells, or all three where relevant. So there is an opportunity for people who are interested in cellular therapies and medical oncologists to get more involved in this process. And where that most of these requirements are covered within the haematology training curriculum, and I'm aware that's probably not the case for medical oncology. There are fellowships and other routes for those that are interested in cellular therapy to get more involved. So, coming back to the principles of stem cell transplant, which are the focus of this lecture. So, delivery of what is stem cell transplant? In its most basic form, we're talking about delivery of hematopoietic stem cells. And this can take two forms. I'm sure most of you are aware broadly that we divide it into autologous and allergenic stem cell transplant. Autologous stem cell transplant includes the patient's own stem cells, hematopoietic stem cells. And essentially all this is a vehicle for delivering high-dose chemotherapy. And it's a very different procedure from allergenic stem cell transplant, which is a type of immunotherapy, which involves donor-derived stem cells. And the reason this is principally given is to manipulate the graft versus tumour effect, i.e. to elicit an immune response that inhibits tumour growth and hopefully cure. So what are the aims? Well, the principal aim for stem cell transplant is usually cure. This is almost exclusively the case for allergenic stem cell transplant, and is usually the case for autologous stem cell transplant. But we also give autologous stem cell transplant to indolent lymphomas where it is not curative. And in these instances, the principal goal is disease control. It's to increase the depth of response, and in doing so, hopefully delay the time until disease relapse or disease progression, and ultimately to improve progression-free and overall survival in these instances. There are some other indications for stem cell transplant, and these are largely in the non-malignant setting, so I won't focus too much on these today. We do give stem cell transplant as gene therapy, often for monogenic diseases that can be cured by delivering hematopoietic stem cell transplant, such as certain immunodeficiencies or hemoglobinopathies. And traditionally that's been the preserved allergenic stem cell transplant, but it's now moving towards the field of autologous stem cell transplant, where we're using ex vivo manipulation of hematopoietic stem cells with technology like CRISPR-Cas9 to cure certain diseases. So gene therapy is going to have a more broader application in future. And the final indication is immunomodulation, and this is most commonly seen in multiple sclerosis, where autologous stem cell transplant is delivered as a means of resetting the immune system and trying to prolong the time for disease progression. So most of the focus of this talk will be on autologous stem cell transplant, and that's because it's most commonly used in lymphoma. An autologous stem cell transplant, as I've highlighted, is a bit of a misnomer. It's not the stem cell transplant that is the active therapy here. It's a high-dose chemotherapy, which is the most important part. And autologous stem cell transplant involves delivering high-dose chemotherapy, which is so intense that the bone marrow take months to recover, or the patient would be rendered permanently aplastic and therefore die of infective complications without autologous stem cell rescue. The autologous stem cell transplant or rescue is purely a means to help the blood system recover from the chemotherapy and to prevent long-term infective complications. And broadly speaking, it's broken down into 3 processes. First, you need to obtain the hematopoietic stem cells from patients, which is usually performed via peripheral blood stem cell harvest. The most important part, as I've mentioned, is the high-dose chemotherapy, followed by the autologous stem cell infusion. But of course, before we even get to that stage, it is important to select the correct patient. And I'll come back to indications in a second. But aside from that, there are 2 very important considerations. Number 1 is fitness for autologous stem cell transplant. So this is an intensive therapy that can only be delivered to fit patients. So we tend to assess their cardiac function, respiratory function using echo and pulmonary function tests in all patients that are being considered for this treatment. Renal function is another important consideration. Impaired renal function doesn't preclude autologous stem cell transplant, but we know that the risks are considerably higher for patients that do have renal impairment. And age is another very important consideration. So we know that the mortality from this procedure in patients who are in their 20s and 30s is probably about 1%. But for patients who are aged over 60, it rises to as much as 10% in some series. So certainly for patients in their 60s, we would only transplant them if they're very fit and non-comorbid. And we very rarely transplant anyone over the age of 70, just because we know that the risks start to outweigh the benefits. The other flip side of patient selection is the patient's disease. And of course, to be able to respond to high-dose chemotherapy, an important prerequisite is that the patient has demonstrated some evidence of prior chemosensitivity before you go in for high-dose therapy as consolidation. So really, high-dose therapy is to consolidate a previous response to chemotherapy. So all patients usually receive some form of salvage chemotherapy, and they have to show some evidence of sensitivity to this before being put forward to high-dose chemotherapy and autologous stem cell rescue. And there are many series that show this, but this is one of them. This is in classical Hodgkin lymphoma. And what this shows is that it doesn't matter whether you have received 1 or 2 lines of salvage chemotherapy, as long as you obtain complete metabolic response by PET, as shown by the blue and green lines here. But if you have a suboptimal response to chemotherapy, or a PET positive in this case, the outcomes are not as good. So patient selection is really key to identifying the patients that will derive the most benefit from this intensive therapy. So peripheral blood stem cell harvest. So how does this procedure work? Well, the first thing that happens is patients receive some form of conditioning chemotherapy. That can be the salvage therapy that they're already receiving, or it can be a standalone dose of something like cyclophosphamide. It doesn't necessarily matter. But the role of this is just to arrest normal hematopoietic stem cell function, so that when the patient starts to recover from the chemotherapy, there is an increased output of immature cells, and that makes it easier to harvest peripheral blood stem cells from the peripheral blood. This process is aided by regular injections of GCSF from the end of chemotherapy right through until stem cell harvest. Patients then, so it's normally about 7 to 14 days after receiving chemotherapy, they attend the hematology day unit where they have a white blood cell count and a CD34 count check, so CD34 being a marker of peripheral blood stem cells. And if these are sufficient, the patients then undergo apheresis, which involves several hours on an apheresis machine, either with large cannulas or more commonly with a central line insertion, which involves removal of blood, centrifugation to remove peripheral blood stem cells, and of course the rest of the blood is then returned. This usually happens over 1 day, but sometimes over 2, depending on the CD34 count that is obtained. And sometimes we use an additional drug, and that's a CXCR4 antagonist, plerixafor. CXCR4 is a key ligand for peripheral blood, for hematopoietic stem cell homing within the bone marrow niche. So by interrupting CXCR4, you can drive more hematopoietic stem cells into the peripheral blood. And this process is successful in the vast majority of patients. And when we define success by CD34 stem cell count, at least 2 million per kilogram of patient weight. What are the important considerations for medical oncologists here? Because a lot of this will be organised by the transplant team, and the involvement of medical oncologists may be minimal. There are a few important things to bear in mind. Firstly, these patients need irradiated blood products, usually from the day that they start conditioning chemotherapy. And this is because any contamination with foreign leukocytes can give a risk of transfusion-associated GvHD, which is untreatable and invariably fatal. So irradiated blood products are mandatory, and if the patients receive non-irradiated blood product, it cannot go ahead. The second important consideration, if you see any of these patients, do not miss a dose of GCSF, or it can compromise the stem cell harvest. And this is the one, if patients have severe bone pain requiring opiates, usually I'd say stop GCSF, except in these circumstances where it's really vital for stem cell harvest. The only minor caveat is a very rare chance of splenic rupture, 1 in several thousand. So left upper quadrant pain can be a red flag, but this is exceedingly rare and not something I've seen in clinical practice to date. So continuing GCSF right up to apheresis is important. And the final point is that any infective complications need to be promptly treated, because they can compromise stem cell harvest too. So once stem cells are collected, they go off to a processing lab, they're preserved, they undergo quality control to check there's no infection or any problems with contaminants in the product. That takes around 2 weeks, and it successfully passes that. So going back, this is a picture of the apheresis procedure and the apheresis machine, just to give an illustration. Presuming patients successfully the product passes quality control, patients are then admitted to start high-dose chemotherapy. We usually denote day 0 as the day of stem cell infusion. The most common regimen of high-dose chemotherapy is the Beam regimen. That's used for most forms of non-Hodgkin and Hodgkin lymphoma. And as you can see, it's a 6-day chemotherapy regimen that starts a week before stem cell infusion, consisting of 4 drugs, so BCNU or carmastine, cytarabine, etoposide, and melphalan. And this follows very similar processes to most chemotherapy we give. We've got different agents that have different mechanisms of action, acting throughout the cell cycle that are non-cross-resistant. And certainly with drugs like BCNU and melphalan, these are agents that the patients won't have seen before in their prior treatment. So patients have 6 days of chemotherapy, and then a 24 to 48-hour washout period, and then the stem cells are infused. And the stem cell infusion itself is actually pretty much a non-event. It's like receiving a blood transfusion. Some people get a bit of a headache because of the anticoagulants that are used for the stem cells, but generally it's just like receiving a blood transfusion. It's a real non-event otherwise. So there are other types of high-dose chemotherapy used, and I do just mention them briefly. So, they're different again in sarcoma, but for CNS lymphoma, we use CNS penetrating agents, so BCNU or carmastine plus thiotepa. Myeloma, we use just 1 drug, and that's high-dose melphalan. You may come across historical regimens that included total body irradiation, but these have largely been phased out because of the late effects. And what are the side effects? So there are a few key side effects to be aware of. So pulmonary toxicity is extremely rare, but can be fatal, and that's related to carmastine. But the most common side effects are the gastrointestinal disturbances with melphalan and some of the other agents. And you really do get diffuse mucositis from the mouth to the anus. Grade 3 mucositis is not uncommon. Patients are usually admitted for a total of around 4 weeks for this procedure, and that's largely because of the side effects that happen following the high-dose chemotherapy. So it's usually about 3 or 4 days after stem cell transplant that patients start to develop mucositis. Many patients need opiates either orally or as a syringe driver. Many patients won't be able to eat for about 2 or 3 days at certain points. And many patients will have diarrhea once or every 1 or 2 hours at its worst. Patients really do feel quite rough with these side effects, but they are short-lived. It's about a week of gut side effects on average, and 2 or 3 days when they tend to be severe. And unsurprisingly, during this period, which coincides with neutrophils being completely flat at 0, the vast majority of patients develop neutropenic sepsis and require antibiotics. In fact, I've only seen 1 patient who's ever got through an autologous stem cell transplant without intravenous antibiotics. And unsurprisingly, with all of this, the transplant-related mortality is around 2 to 3%. But it's short-lived, and most patients after treatment recover within a few weeks. The one late effect to be aware of is a chance of secondary myelodysplasia and leukemia. And that partly depends on the transplant and partly on what chemotherapy they've received before. The risk is probably between 1 and 3%, depending on what series you read. Supportive care is absolutely key, and patients receive a wide range of effective prophylaxis, and those have really been key in improving outcomes with transplant over recent decades, along with PPIs, loperamide, GCSF and blood product support. So important for the medical oncologist, what are the post-transplant considerations? So these patients will typically be referred back to the lymphoma team at 30 days to 100 days post-transplant, depending on the circumstances. Well, these patients are immunosuppressed. They're not as immunosuppressed as allergenic transplant recipients, but they are still immunosuppressed. They typically receive PCP and VZV prophylaxis for 6 months post-treatment. And at the Christie, we recommend revaccination against childhood illnesses at 6 months post-transplant, although practice varies around the UK and the evidence is variable. These patients require irradiated blood products for 3 months post-autologous stem cell transplant, or longer if they've got Hodgkin lymphoma, it's lifelong. If they've had purine analogues, it's lifelong. But for all other patients, it's 3 months post-transplant. And the other thing to bear in mind when they're referred back is there any benefit for further treatment? For most patients, autologous transplant represents the end of treatment, but there are selected patients with limited stage disease or refractory disease that may warrant radiotherapy to certain areas, which is usually something that's discussed at MDT. And there are some indications for maintenance treatment, particularly in mantle cell lymphoma, where patients receive rituximab maintenance for 3 years after transplant. But I'll move on because I think it's important to discuss the indications for autologous stem cell transplant. So what strikes me with this is how little treatment has changed in 25 years. So in DLBCL, or relapsed and aggressive non-Hodgkin lymphoma, the evidence for transplant comes from the PALMER trial, which randomised patients between DHAP salvage or DHAP plus high-dose therapy and autologous stem cell rescue. And you can see here that there is clear overall survival benefit from transplant versus chemotherapy without autologous stem cell rescue. And there is similar data in Hodgkin lymphoma, although slightly weaker, admittedly. This is a British trial that compared non-myeloablative doses of beam chemotherapy, so 2 to 3 cycles of mini beam, versus myeloablative beam followed by autologous stem cell rescue. And again, this is event-free survival. You can see there is a very clear advantage for beam, albeit in a very small trial, which wasn't powered to find an overall survival advantage. But there's been one subsequent trial that reinforces these results. We've looked at whether there is any role for autologous stem cell transplant in the front line for DLBCL or aggressive lymphoma. The answer is no. This is one of multiple randomised trials conducted in this setting. And whilst you can see that there is a slight progression-free survival benefit for autologous transplant of around 14% in this trial, which included patients with intermediate to high risk DLBCL. There is no discernible overall survival benefit. And that suggests that actually the patients that you're salvaging or preventing relapse with autologous stem cell transplant on the left are the ones that you could salvage at relapse anyway. And of course, 84% of patients do not derive any benefit from intensive therapy. Therefore, autologous stem cell transplant is not used frontline in aggressive DLBCL, with the exception of CNS lymphoma. And I think time is short, but essentially autologous stem cell transplant is equivalent to what was the standard of care, a whole brain radiotherapy, but has fewer long-term side effects. So that's the one caveat for frontline transplant. We also use autologous transplant in indolent lymphoma. We use it frontline in mantle cell lymphoma, and this is the trial that showed it. It showed the benefit. So this was a randomised trial in mantle cell lymphoma of interferon maintenance, which was considered the standard of care at the time, versus one cycle of more intensive chemotherapy plus high-dose therapy and autologous stem cell rescue. And you can see there's a clear progression-free survival for autologous stem cell transplant. And on a pooled analysis of randomised trials, there's probably an overall survival benefit too. For all other forms of indolent lymphoma, there is no benefit for frontline autologous stem cell transplant, but there is a progression-free and probably an overall survival benefit in relapsed lymphoma. And we know that it is better if given early, so in first relapse, rather than at subsequent time points. And the data on the right show that for patients who relapse early following frontline immunochemotherapy, that the best outcomes are achieved if they receive a transplant within 1 year of completing salvage therapy of relapse rather than at subsequent time points. So to summarise the current evidence, autologous stem cell transplant has a key role for chemo-responsive patients with relapsed non-Hodgkin and Hodgkin lymphoma and high-risk indolent non-Hodgkin lymphoma. You'll probably have seen from this data that the trials are frequently small and or underpowered. And the big problem that we have is that a lot of this data is 20, 25 years old, pre-rituximab or using outdated treatment regimens, and really does need updating with our current practice. And we do need better biomarkers to work out who derives the most benefit. We do have, there are a lot of emerging biomarkers, cell-free DNA, etc., and PET as an imaging biomarker. So there's a lot of research to be done to find out who benefits the most. The current available evidence, it's very difficult to risk stratify the patients. And the role of transplant in very late relapses, so 5-10 years out of primary therapy, is unknown. So we need better evidence for autologous stem cell transplant, but it can be difficult to conduct trials. And one of the big problems that these trials have faced is that these randomising patients, often clinicians think they know what is best before the trial reports, and often patients have strong feelings about what they do and don't want, so it can be very difficult to conduct trials in this setting. So I'm slightly over time now, so I'm going to very quickly talk about allogeneic stem cell transplant. So the intention of an allogeneic stem cell transplant is to induce a graft versus lymphoma effect. And there are several reasons we know that this exists. Firstly, because we can identify and isolate tumour-reactive T cells against tumour-specific antigens. We know that purely by reducing immunosuppression, we can induce remissions in lymphoma. And for those that have persistent lymphoma after allogeneic transplant, we know that by infusing donor lymphocytes, we can sometimes induce remissions. We also know that relapse rates are very low after allogeneic stem cell transplant, lower than you would see after autologous stem cell transplant or chemotherapy alone, which provides further evidence of a graft versus lymphoma effect. But a graft versus host effect is common, where the bone marrow reacts against normal recipient tissue. And that manifests often in acute graft versus host disease, which is skin toxicity, gut toxicity, and liver toxicity, as well as chronic scarring GVHD. And what we often find is that graft versus lymphoma effect is accompanied by a graft versus host effect. So a little bit of GVHD, graft versus host disease, often is associated with lower relapse rates. But for patients who get severe graft versus host disease, outcomes are compromised and it can often be fatal. So one of the key difficulties with the transplant team is to make sure that patients are immunosuppressed enough to prevent fatal graft versus host disease, but not immunosuppressed so much that they stifle any graft versus lymphoma effect. And this is a difficult balance to have. So what you can see here is true for most types of lymphoma. So we can see this is retrospective data in follicular lymphoma. Matched unrelated donor and matched sibling donor are two different donor types, but both represent allogeneic stem cell transplant, and here compared with autologous stem cell transplant in follicular lymphoma. And you can see that non-relapse mortality, transplant-related mortality, is much higher with autologous, with allogeneic than autologous transplant, but relapses are much lower. And these two things often balance out. So comparing autologous versus allogeneic stem cell transplant, in general in lymphoma, there's no overall difference in progression-free or overall survival. With the caveat that in indolent lymphomas, we start to see, which are not cured with autologous stem cell transplant, there is the potential for cure. So we do start to see a plateau in PFS and OS with allogeneic transplant, which we don't see with autologous transplants. So when we extended these curves out to 20 years, we may start to see a benefit for allogeneic transplant. So the role in lymphoma is predominantly confined to relapse after autologous stem cell transplant or failure of autologous stem cell transplant, or disease refractory to multiple lines of chemotherapy. So chemosensitivity is a prerequisite for autologous stem cell transplant, but not so much for allogeneic stem cell transplant. And we also consider allogeneic stem cell transplant in young patients with indolent lymphoma after very careful considerations of the risks and benefits. And I'm going to skip most of the next slide, but the transplant-related mortality is 10 to 30%, depending on fitness, donor choice, and indication. So we don't undertake it lightly. But my final point I want to make before finishing this talk is where we're going in the future. And I think you'd have to live in a bubble not to know that CAR T cells are emerging in lymphoma, and they are certainly now starting to challenge the role of stem cell transplant. And we had two very recent press releases within the last month from randomized trials comparing CAR T cell therapy versus autologous stem cell transplant in relapsed DLBCL. And these are press releases. We haven't seen the full data, but there's certainly event-free survival and probably a progression-free survival for CAR T therapy over stem cell transplant. And it's quite probable that CAR T cell therapy will start to take the place of autologous stem cell transplant in certain circumstances, but we need to see the full data. On the left, we can see follow-up of autologous stem cell transplant for DLBCL, which shows a probable PFS and OS plateau in about 40%. So it is likely to be curative, although the scales have been stretched here by the authors to give a fairly exaggerated effect, but there probably is a survival plateau here. So long-term follow-up data will be key in these trials. Does CAR T improve cure rates and overall survival over autologous transplant? And toxicity and cost are going to be important considerations here. Toxicity and resource intensiveness are probably similar between autologous stem cell transplant and CAR T, although slightly different. But cost is an important consideration. CAR T costs about $250,000, whereas autologous stem cell transplant, we're looking at least half of that, slightly less. So I will summarise very quickly. Stem cell transplant, particularly autologous, has a key role in the management of non-Hodgkin lymphoma and Hodgkin, particularly at relapse, but patient selection is vital. Allogeneic stem cell transplant has a more limited role, but is important for multiply relapsed and refractory disease. But CAR T is waiting in the wings and is likely to challenge the role of stem cell transplant in the very near future. Thank you for listening. I don't know whether you want to take questions now or later, Rachel.
I thought we would ask questions now, so hopefully our attendees can type them in the chat if they have any. Thanks very much for that talk. It was really enlightening. I've actually learned a lot. And I'll kick off, if that's okay, with a couple of questions. Obviously, you said that autologous stem cell transplant, one of the indications for that is that the patient has demonstrated chemosensitivity. But I just wondered, in view of the fact, particularly in Hodgkin lymphoma, where we're using checkpoint inhibitors at relapse and other, non-traditional chemotherapy type agents, whether there's any emerging evidence for transplant post receipt of one of those agents if the patient was in metabolic response.
Yeah, thanks for highlighting that. That is a really important point to make, actually. So, yes, there is the answer. I've got to say, I think checkpoint inhibitors are the only kind of pure immunotherapy we give. A lot of the other immunotherapies are kind of conjugate, things like brentuximab are conjugated to classical chemotherapy. So, in that sense, they often do demonstrate chemoresponsiveness to things like brentuximab. But for immune checkpoint inhibitors, it was an open question. If you respond well to a checkpoint inhibitor, do you respond well to autologous stem cell transplant? And there's some data that's emerged in recent months which shows that patients with in Hodgkin lymphoma with partial or complete response after checkpoint inhibition actually have very good outcomes after autologous stem cell transplant. So yes, response to immunotherapy is an indication for autologous stem cell transplant, but we do need a bit more data, and I know that there are clinical trials ongoing to get a bit more evidence. At the moment, we're reliant on retrospective data and case series, which is not ideal.
Thanks for that. There was a question in the chat, which was with regards to CAR T therapy coming into practice. The question is about the length of the admissions compared to stem cell transplantation, and the second part of that question was that the CAR T is currently limited to a small number of centres, and how is that expected to be able to scale up if that becomes the standard practice over stem cell transplantation?
So point number one, I think, and I'm sure Adam may want to come in with points on this, but so admissions tend to be as lengthy as CAR T because you've got conditioning chemotherapy, you deliver the CAR T, and then observation for at least 14 days afterwards. So yes, the admissions the process is fairly similar. Many centres are moving to kind of ambulatory care protocols, and that for both autologous and CAR T therapy. So no, there isn't really a huge amount to differentiate between them, but some of the CAR T products that have lower rates of CRS and neurotoxicity may start to move into the outpatient setting at some point. But at the moment, there isn't a huge amount in terms of resource intensiveness and resource use between the two. In terms of CAR T limited to very few centres, I understand that the indications of CAR T will widen, particularly within haematology in coming months, and there are plans that all transplant centres will become CAR T centres in the very near future. So that will widen things considerably, but probably not sufficiently if we're starting to think about solid cancers. And I think configuration services is a really important consideration. I think we're going to start needing dedicated CAR T teams. And hopefully there will be more scope for medical oncologists to get involved with that. As I say, there's the potential to accredit medical oncologists within their scope of practice. So hopefully we'll start getting more multidisciplinary input for some of these cellular therapies.
Yeah, it's a really interesting field, very much emerging. I just have a final question, which is really in terms of the patient fitness, because we know for stem cell transplantation, you really need patients to be of very good performance status and able to tolerate the toxicities. And is there any difference between the level of fitness required for stem cell transplantation and CAR T therapy?
That's a good question. Yes, there is. So I think there's data that you can give CAR T to older patients, and patients with some comorbidities. So there's data emerging there. So I think that CAR-T will widen the availability of effective salvage therapies, particularly in older patients. And that's really relevant to something like DLBCL. The median age at presentation is 65. So, the majority of patients, well, at least half of patients are unlikely to be eligible for stem cell therapy that need it. So I think CAR-T will widen the indications slightly. But not a huge amount, but there is some difference.
Okay, thank you.
I don't know if Adam wants to quickly comment on that.
No, concur. I think that you can probably be a little older and sort of less cardiovascularly fit to undergo CAR-T. Certainly the process itself, although the sort of post-CAR-T rigors of immunosuppression and subsequent infection it can be challenging, but yeah, there is some data now published showing that CAR-T for older patients is as safe as it is for younger patients, providing you lack comorbidity, and it's actually probably the comorbidity which is the major risk factor.
Okay, great, thanks for answering that. So that leads me to introduce Dr. Gibb, who's our second speaker of the night. So Dr. Gibb trained in Newcastle upon Tyne in the 1990s, and he's been working with Professor John Rad as a clinical research fellow in lymphoma at Christie since 2009. And is working as part of a busy clinical research team consisting of over 10 physicians and research nurses, seeing over 100 patients per week, and is a sub-investigator in a portfolio of over 30 currently recruiting trials, the majority of which are early phase novel agents. He has multiple publications in the field of lymphoma, including first author of the Brevity study of brentuximab vedotin in older, frailer Hodgkin patients. This evening, Dr. Gibb is going to present an overview of diffuse large B-cell lymphoma, including recent progress in therapeutic options. So, Adam, please go ahead and share your screen.
Great, I think that should be up on everyone's screen now. So yes, and I'm somewhat less cleanly shaven than my biopic. Diffuse large B-cell lymphoma is, of course, the commonest lymphoma in the UK, the commonest NHL in the Western world, and this is an aggressive malignancy arising from B lymphocytes at varying stages of maturity. It is repeatedly classified, reclassified, and subtyped by the WHO, who publish their sort of atlas of the hematopoietic and lymphoid malignancies every couple of years. Most recently in 2016, I believe there's another one due to come out later this year. And if we look at trends over time, the number of new NHL diagnoses, so most of these will be diffuse large B-cell lymphoma, is increasing as the years roll past, even if you correct for demographic shift. So spookily, something out there is causing lymphoma, but we don't really know what this is. Most cases are idiopathic and sporadic, rarely there will be defined triggers. So the classics, ionizing radiation, nasty chemicals, particularly those from the dye and solvent sort of organic chemistry end of the spectrum. We know there's a genetic link. So if you look at family history studies, there's a relative risk of around twofold between first generation family members. But if you look at GWAS studies, candidate SNPs are actually reasonably common in the general population. So that's not quite clear what the link is. Selected viral and bacterial infections will be the cause of some lymphomas. In HIV, particularly prior to the age of highly active antiretroviral therapy, there was an 18-fold risk, and H. pylori is a risk factor for gastric diffuse large B-cell lymphoma, and a similar story for those people who are immunosuppressed. In terms of the genesis of diffuse large B-cell lymphoma, we can see here on the left-hand side of the slide sort of the maturation of the lymphocyte from the precursor, and it's really over towards the middle of the screen here as we sort of begin to undergo antigenic education. that the DLBCLs are generated. The little cartoon down in the bottom right illustrates the genetic events. So looking at translocations amongst genes, we'll come back to these in a couple of slides, particularly those involving proliferation and apoptosis, mutation of the guardian of the genome, P53, and other mutations of relevant, typically anti-apoptotic genes. So some of these very common genetic oncogenic partners in diffuse large B-cell lymphoma are MYC, which is expressed in highly proliferative tissues, is involved in apoptosis, regulation of gene expression, and sort of drives a very proliferative tumor. And then the B-cell lymphoma families, particularly 2 and 6, which when they're overexpressed, resist apoptosis. And of course, many anti-cancer agents, both new and old, have apoptosis as a major mechanism of action. So this leads to some of the more modern nomenclature in lymphoma, characterized in the most recent WHO classification 2016, and in the lingo we call these the hits. So if you have a translocation in 1, 2 or 3 of the MYC, BCL2 or BCL6 genes, then you're single, double or triple hit lymphoma in the lingo. Typically the translocations are between these genes and an IGH promoter region, so we're typically sticking a go next to a grow or a go next to a don't die gene, and you can only imagine how these translocations produce very effective resistant tumors. So the nomenclature deepens further, so we cannot merely subdivide the diffuse large B-cell lymphomas by whether they have the MYC BCL translocations, the hits. We can also divide by gene expression profiling into the so-called ABC and GCB subtypes. You may merely overexpress MYC or BCL gene products, become a double expressor. And increasingly, there's a concept of high-grade B-cell lymphoma, which carries various of these translocations, and this is being separated in the modern era from sort of the classic card-carrying DLBCL. So sort of morphology across the top here and molecular aberrations across the bottom. If we look at high-grade B-cell lymphoma, this is forming between around 5 and 10% of diffuse large B-cell lymphomas, and is classically a very rapidly progressive and widespread disease with some very high-risk features. So it's almost always advanced stage, elevations in the lactate dehydrogenase, frequently leukemoid in presentation with circulating NHL cells in the peripheral blood, and central nervous system involvement is also relatively common at 10%. Of some interest to the audience, as primarily I imagine solid tumor physicians, is of course the immune system and the microenvironment. I'm obviously aware that the immune checkpoint inhibitors are widely used in many solid tumors, but most lymphomas, including diffuse large B-cell lymphoma, harbor a non-inflamed microenvironment. And the mechanism here is two thoughts in cartoon A, that the tumor is simply so rapidly proliferative that it simply excludes the immune system from the tumor. Or in cartoon B, selected mutations including EZH2 sort of downregulate HLA expression and induce a very immunosuppressed microenvironment, which therefore does not play to the strengths of sort of checkpoint and PD-1 inhibition. This was really shown in a phase 2 study of nivolumab in relapsed and refractory disease, where the overall response rate was a mere 10%. And in fact, if you were not eligible for a stem cell transplant, the response rate was only 3%. Nevertheless, several durable responses were seen, and this probably attests to the small minority of patients who harbour a sort of an inflamed tumour. Moving on then to current therapy. Well, of course, R-CHOP is the standard of care in diffuse large B-cell lymphoma. So rituximab, the original targeted therapy, was developed in the late 80s, and randomized trials of CHOP versus rituximab CHOP took place in the 1990s, and very rapidly following this, FDA and NICE approvals. And we can see here on the right-hand side of the screen the updated results in 2007 of the seminal GLAS study of CHOP versus R-CHOP in older patients with DLBCL, demonstrating a clear and maintained overall survival advantage for rituximab containing therapy. That can be contrasted to some studies taking place in the 1980s, shown on the left, whereby essentially additional chemotherapy, classic cytotoxics, were added in sort of layers to CHOP, making the delightfully named M-BACOD and a pro-MACE cytobomb, but demonstrating no improvement by adding more and more cytotoxics. But as soon as you bring in an immunotherapeutic, you gain traction. So where does this leave us then? So R-CHOP sort of is around 20 years old now, but we know that R-CHOP is not an optimal therapy for all. So if you begin to stratify diffuse large B-cell lymphoma patients by a prognostic score, so this is the most commonly used here, the IPI, a 5-point score based around age, stage, lactate dehydrogenase performance score, and whether your disease involves multiple extranodal locations. You only have to score 3 or more points to actually have an overall survival at 5 years of only 50% with R-CHOP, contrasting to low-risk patients who have OS of 90 or 80%. We also know that selected molecular classifications can infer worse prognosis. So we spoke briefly before about this ABC-GCB split by gene expression profiling, and we can see here that the red ABC patients perform worse with PFS and OS than the blue GCB patients. And not dissimilar data can be demonstrated if you express the MYC and BCL gene products at the surface. So this top tranche of Kaplan-Meier's demonstrates GCB best performing, ABC intermediate, and double express are worse. And at the bottom here, people who are double hit lymphoma, who have a fairly dismal overall survival of under 40% with R-CHOP. Even if you intensify such patients, so some of the multicolored survival curves here, we still can get survivals up 50% or less if you have high-grade B-cell lymphoma, particularly with the double hit translocations. So what are sort of the questions then posed to investigators in the modern era for diffuse large B-cell lymphoma? Well, we know that you can identify poor risk patients through high IPI or adverse molecular features, and therefore there's a pressing need to sort of improve the frontline therapy. As discussed, R-CHOP is now 20 years old, and some of the thoughts that therefore have been had are, can you give more chemo? Can you consolidate with stem cell transplant in first remission? Can you give your chemotherapy in a smarter fashion? What about new drugs, or sort of using drugs in different ways? Can you maintain remissions? So the French developed a very intensive regimen, so-called ACVBP, that takes 30 weeks to crank through, the initial 11 weeks in the outpatient department and the following 19 weeks in the inpatients. and it incorporates drugs like Vindazine, which, like their fine cheeses and wines, they won't sell outside of France. They do claim a small survival advantage, but this is very toxic, very difficult to deliver, and it really hasn't been adopted by the international sort of lymphoma profession. As Dr. Phillips alluded to, there have been multiple studies of varying sizes and qualities of looking at stem cell transplantation, typically autologous, consolidation of first remission in diffuse large B-cell lymphoma. If you meta-analyze these, so this forest plot here, straddling unity, no benefit to transplanting remission 1. Some very clever Canadians decided that most diffuse large B-cell lymphomas cells will undergo mitosis at least once within a 96-hour window, and therefore if you smear out your CHOP over 96 hours, throw in an additional inhibitor of topoisomerase 2, such as etoposide, and then crank up the doses until patients repeatedly hit grade 4 neutropenia, you might be able to improve upon R-CHOP, so the fantastically named dose-adjusted rituximab EPOC. And in phase 1 studies, this was spectacular with a 100% overall response rate. But in the randomized trial, there was no difference between R-CHOP and DA-EPOC-R. The Brits came along and thought we're going to do some very fancy gene expression profiling in real time, identify ABC diseases. We know that ABC disease is dependent or addicted to NF-kappa beta. That drug bortezomib from the world of myeloma inhibits NF-kappa beta, so why don't we randomly allocate people to receive R-CHOP or R-CHOP with bortezomib and stratify the randomization by your genotype? Forest plot straddles unity, no benefit in that study. As all this is occurring, Roche have noticed that rituximab is running out of its patent period. They better develop a new 3rd generation antibody. So obinutuzumab comes along. In the lab, it looks fantastic. The phase 2 study looks fantastic. They recruited nearly 1,500 patients to a randomized trial of rituximab CHOP versus obinutuzumab CHOP, and found no difference in 3-year PFS or response rates. And then lenalidomide is an expensive tablet from the world of multiple myeloma. There is phase 2 data showing responses in relapse disease, so perhaps you could give it for a couple of years after your R-CHOP and earn a couple of $100,000 worth of drug sales, but the 95% confidence intervals of this maintenance trial straddle each other, and this was a non-significant trial. You could also give your lenalidomide up front with your R-CHOP, R-squared CHOP in the lingo, so the robust trial demonstrated no benefit. And ibrutinib is a very interesting drug from the world of CLL and mantle cell lymphoma. The Phoenix trial was a randomized trial of R-CHOP plus or minus ibrutinib. Interestingly, it did not meet primary endpoints in the all-comer DLBCL group, but slightly provocatively, if you had a double hit lymphoma, then maybe it did improve your outcomes to as if you didn't have those adverse genetic features. So ultimately, about 40% of patients with diffuse large B-cell lymphoma will fail R-CHOP, and of course the standard of care for these patients is stem cell transplantation, as alluded to by Dr. Phillips. The Palmer trial of short course salvage with transplant versus long course salvage and no transplant was clearly in favor of undergoing transplant in remission 2, contrasting to no benefit in remission 1. Isn't biology a fickle mistress? That of course, was a study in the age prior to rituximab, so we repeated it in the age of rituximab and noticed that really the outcomes were very, very poor. Although we were seeing a plateau in survival, it was down at 17%. So really, if you fail R-CHOP, you're going to do very, very badly. And this was looked at in the SCHOLAR-1 study, so meta-analysis of multiple data sets from several clinical trials, several large intergroups. Fundamentally, if you fail first-line chemotherapy, second-line chemotherapy, and or stem cell transplant, you have a median overall survival of approximately half a year. The tail of this survival curve is fundamentally the transplant survivors. So where does that bring us to then? Well, new agents in diffuse large B-cell lymphoma. The Christie lymphoma team in the past decade has done clinical trials of most of these alphanumerically code-named small molecules, and fundamentally they're all relatively rubbish. There's a little bit of traction of ibrutinib if you have a relapse of non-GCB, diffuse large B-cell lymphoma. Selinexor is relatively rubbish, but they did gain a recent FDA license. We'll come to this shortly. But most of the small molecules are not really going anywhere in relapse disease. Of much more interest is antibody-based drugs. So antibody drug conjugates, as you'll be familiar, sort of link a very potent intracellular toxin to a targeting antibody. Brentuximab vedotin from the world of Hodgkin lymphoma was the forerunner with really spectacular results in relapsed Hodgkin, but that didn't translate across into diffuse large B-cell lymphoma. But a derivative of brentuximab vedotin, polatuzumab vedotin, has been successful in relapse and has gained a license, and a similar drug, ADCT-402, now called loncastuximab tesirine, also successful. The Selinexor study, the waterfall plot is demonstrated here. They had an overall response rate of 29%, a complete response rate of 13%, and relatively few durable responses. Only 15% of the responders had responses greater than 12 months, but nevertheless they went to the FDA and gained a license last summer. Bizarre. Polatuzumab vedotin is an ADC, as illustrated by this little cartoon here. They actually did a randomized phase 2 of immunochemotherapy, so rituximab with bendamustine versus rituximab bendamustine plus polatuzumab in a relapsed diffuse large B-cell lymphoma setting who were ineligible for transplant, and they demonstrated improvements in both progression-free and overall survival, as shown in the Kaplan-Meiers here. So they gained FDA approval in 2019 and NICE approval in 2020. So this is now a standard of care for patients in the UK who have relapsed diffuse large B-cell lymphoma who are either ineligible for a stem cell transplant or perhaps they've relapsed after a stem cell transplant. Loncastuximab tesirine is a relatively novel ADC, so incorporated an extremely potent payload that's got potency at 10 to the minus 12 molar. They had quite an impressive waterfall plot in their phase 2 trial with an overall response rate of just under 50% and about half of those complete responses, and they gained FDA approval this spring. Tafasitamab is an anti-CD19 naked monoclonal. It's not actually a conjugate, but they've got engineering of the Fc or constant region of the antibody, so you get an enhanced immune effect. Due to that, they did a phase 2 study with lenalidomide, the L-MIND study. This was quite impressive. They gained FDA approval this summer. Here they showed an overall response rate of nearly 60%, and 2/3 of these, or 40%, were complete responses. If you were a responder, your median duration of response was just under 3 years, and this was without stem cell transplantation. I think that's very provocative data indeed. Would really like to see a randomized phase 3 follow on from this. Finally, last couple of slides, the T-cell bispecifics are extremely interesting and may indeed challenge CAR-T over time. So these are basically two-headed antibodies. One head grabs the tumor, typically through CD20 or perhaps CD22. The other head grabs a T-cell through CD3, enforces an immune synapse through which perforin and granzyme flows and destroys the tumor cell. The most mature of these molecules is mosunetuzumab, showing an overall response of 37%, complete response of 19% in a dose escalation phase 1 trial. And in the slide in the bottom right, demonstrating responses in 18 patients treated post-CAR-T failure. Around half of those responses were associated with reactivation of the CAR-T cells themselves. The other half of the CAR-T remained dormant. Other molecules in this field, epcoritamab, odronextamab, plamotamab, and I can't even say some of these, are also demonstrating fairly impressive response rates in their early dose escalation trials. So I think that brings me in roughly on time. Thank you very much. I'll be very happy to take questions and stop sharing my screen.
Thanks very much for that, Adam. It's really comprehensive overview, and there's obviously so many new agents emerging in the field. I'll just ask attendees if they want to any questions in the chat, and I'll ask them for you. In the meantime, I just wondered, I mean, I noticed that on one of the slides you showed, I can't quite recall which one it was, sorry, but on one of the slides where they added an agent to R-CHOP, essentially,
yes,
to see if it was superior, there was only one Kaplan-Meier that showed that they had stratified patients according to the molecular subtype, I think. Has that been an issue in those kind of trials, that they've not adequately stratified patients who are at higher risk of relapse, which might have impacted the result?
The study which stratified people as the primary stratification, so the prospective design was the UK NCRN remodel B study. So that used gene expression profiling to stratify people between the so-called GCB and non-GCB, aka ABC subtypes, and then randomized with stratification by said phenotype, and that study did not show any benefit to the addition of bortezomib either to the ABC or GCB subtypes. The other slide that you might be alluding to was the Phoenix trial. So this was a trial where people were randomized to receive R-CHOP or R-CHOP with ibrutinib. That study didn't use gene expression profiling. It used an immunohistochemical correlate of gene expression profiling that's only around 80–85% accurate. That study didn't demonstrate any benefit according to its primary outcome measures, but when they did, I think it might have been post hoc analysis on patients who were double hit. They demonstrated some benefit, but I don't believe that was powered. So okay. It's provocative, but it's not practice changing.
Yeah, it seems like all the data so far suggests that, you know, that there is nothing superior to R-CHOP in the first line.
First line, yeah. You're right. There's no definitive data across all of those multiple studies. R-CHOP remains the gold standard. You can cherry pick data from subgroups and different ages and a bit of this and a bit of that, maybe to say, oh, intensifying therapy or adding a novel agent. But I think we have to be very cautious when we do such things. You know, there's costs, financial, toxic, and mortal to some of these decisions.
Yeah, I think that partly answers one of the questions in the chat with regards to double hit DLBCL doing, they do less well with R-CHOP, and is that still a regimen of choice? I suppose the answer is widely yes, but they've asked also about Arcodox and IVAC.
So this, I think, is a very hot topic, and I think we ask ourselves, if I had double hit lymphoma, would I receive R-CHOP or would I wish to receive Codex and IVAC? I have to say I'd probably elect to receive Codex and IVAC. I'm still relatively young. I hope all the attendees agree. But there's no randomized data to support this. It's all largely retrospective series, meta-analysis, post hoc subgroup analysis, single arm phase 2s at most. Trying to do a randomized trial when you've only got double hits, according from series to series, double hits between 3 and 11% of DLBCL. So the number of recruits, or the number of people you'd need to screen in order to get an adequately powered study would be very difficult indeed. I don't think any commercial sponsors would take on such a study. It would have to be a national or international intergroup. And there's big differences between R-CHOP delivered in the outpatients, tolerable to patients in their 70s, for example. Codex IVAC is very toxic. Once you start getting, into your 50s or even in your 40s with comorbidity, there's a significant morbidity and mortality to Codex IVAC. And it also largely mandates inpatient therapy for up to 12 weeks. That's very complicated.
Yeah, there's a final part to that question which I thought was really interesting, which was, in patients with DLBCL considered unfit for R-CHOP, what do we do? I mean, I recall patients that we've treated at the Christie in their 80s who are extremely unfit as a result of the disease rather than comorbidities. But I wondered, what would be the approach if you really didn't think it was feasible to deliver R-CHOP? So,
because we have to think about how or why people might be unfit for full dose R-CHOP. If they're unfit because they've got poor performance because of aggressive lymphoma and reduced reserve due to age, then giving people dose reduced R-CHOP is a very effective strategy. And indeed, there is pretty good data showing that over the age of 80, dose reduced R-CHOP is as effective as full dose R-CHOP because you're balancing effect versus side effect in that older population. And actually some quite good, long-term, in inverted commas, survival can be achieved in that older age group, who of course have many other competing risks for death. And all you're really trying to do there is delay the lymphoma relapse beyond the patient's otherwise sort of natural life expectancy. In patients who are unfit for R-CHOP due to comorbidity at a younger age, perhaps they've got cardiovascular disease, they can't receive an anthracycline, we might substitute in gemcitabine. That has been done in a non-randomized fashion. Those patients do badly, and they have a very high treatment-related mortality through both cardiac and non-cardiac mechanisms, even though they're not receiving an explicit cardiotoxin. I suppose it just goes to show that having a fit cardiovascular system is pretty important if you're going to receive chemotherapy of any format.
Our presentation tonight does contain 2 polls which we invite you to take part in. Tiana Kordbacheh is an ST6 trainee in medical oncology at the Christie in Manchester, currently working in the lymphoma team. We're quite a biased panelist group tonight, geographically. So anyway, look forward to your case presentation. Tiana, do you want to try and share your screen, please?
Yeah, hi, thanks for inviting me, and thanks for the great talks. It shouldn't take more than 5 to 10 minutes, might conjure up some discussion. I've chosen a DLBCL case specifically because of Adam's talk. So I'm going to talk about Mr. B. So this is a 70-year-old man who we saw in a new patient clinic. He's got a past medical history of some LV dysfunction, which was stable. He had an ejection fraction of 47 to 51%. And had angina diagnosed in the 60s, but hadn't since had any significant cardiac events. He was able to walk significant distances without any onset of symptoms. He originally presented with left-sided teeth issues, had seen his dentist, and a small lump on the left side of his nose in November last year. He'd had a root canal, a couple of courses of antibiotics, and a tooth removed, but because of ongoing issues in that area, it led to a referral for CT imaging in early December, which showed that there was a hard palate lesion with extension into the maxillary antrum and into the floor of the left nasal cavity. So he then went on to have a biopsy of the gum area, which showed a DLBCL. And this was highly proliferative with a Ki67 index of 100%, and he was double expressor BCL26. He had a PET scan which showed the destruction lesions within the hard palate, the maxillary alveolus and anterior maxillary wall, and then the nasal bone, just a couple of pictures to demonstrate that high avidity here. The PET scan also showed that he got left adrenal nodules, which you can see in the image here. So he went on to have first-line therapy of R-CHOP. They were satisfied that his cardiac function was sufficient enough to complete that, and he tolerated 6 cycles very well, with one septic episode which sounded non-neutropenic, necessitating a 48-hour hospital admission. And luckily for him, he achieved complete metabolic response in April of this year. So this was the point at which we were seeing him. And I wondered to attendees tonight, what would be your next most immediate concerns with this case? Right, so most people are saying distant disease and secondary CNS relapse. Okay, so I'll just close that down. I guess in reality, it's all of those. I guess it's a bit of a mean question in terms of immediate concerns. The disease in his maxillofacial area is quite nasty. And one of the considerations here would be to deliver local radiotherapy to that area. But of course, with his R-CHOP therapy, he won't have had sufficient treatment to treat any CNS disease. So that would be of an immediate concern. And some of those things that we might use to help judge the state of our concerns are things like the initial International Prognostic Index score, and also the CNS IPI score for DLBCL. So as Adam discussed, there are various factors that make up the score, and for this patient in particular, he was 70 years old, he got advanced stage disease. We weren't informed what his baseline LDH was, so we'll say that was negative. His PS was 0 to 1, and he had 2 extranodal sites. So straight away, he's at 3 points on the IPI score, which puts him down in this worrying category where, the 5-year overall survival levels fall down to about 50%. And then with regards to the CNS IPI score, it does put in the extra factor here of kidney or adrenal special site involvement, which then puts his score up to 4 and puts him into a high risk category for CNS progression. And when you look at that, that overall risk stratification at 2 years, his risk of developing CNS disease is 10.2%. So considering that, the next options would include local radiotherapy to minimise local and reduce the risk of distal recurrence, particularly in a hard to treat area, and also CNS prophylactic systemic therapy in the form of high dose methotrexate, which is given nationally in 2 to 3 cycles, 2 to 3 weekly, usually 3 weekly potentially, and usually given to patients who have a CNS IPI score of 4 to 6. And these patients will have involvement of a special site, which includes the adrenals, testis, breast, kidney, perineuraxis areas. They have to be in complete metabolic response after their first initial primary treatment. And then obviously there are some cautions. So age over 70 years, this gentleman was 70 and borderline. He had good performance status, didn't have significant comorbidities other than his cardiac history. Certainly for someone who's got hepatorenal impairment, there would be some cautions, and obviously if you've got an EGFR of less than 30, that would be an absolute contraindication. Interestingly, significant infusions would be something to bear in mind, because in any effusions or third spacing of fluid, you're going to get accumulation of methotrexate, and then recent spinal radiotherapy as well can reduce how well people are able to excrete methotrexate. So given those considerations, another poll, which would you give first out of these options? Probably the high-dose methotrexate, to minimise potential side effects for this gentleman. So he's going to get radiotherapy delivered to his maxillofacial area. That may increase the risk of mucositis, esophageal symptoms. So giving his methotrexate first helps to reduce the intensity of those symptoms. But we had these discussions ourselves at the Christie for this patient, and obviously his radiotherapy is very important, and the methotrexate treatment is not an actual treatment, it's being given here as prophylaxis. So we opted to treat this patient with high-dose methotrexate first, and to see how he went with that initially. So overall, he received 2 cycles of methotrexate. In the first cycle, he cleared that within 96 hours, potentially a bit slower than some patients that would be around 3 days, but not really. And it didn't really have any other adverse events or complications. Unfortunately, his second cycle, he developed stage 2 acute kidney injury. His creatinine shot up to 250, his EGFR dropped down to 20. It took around 6 days to completely clear his methotrexate, and he's only just started to turn the corner, having seen him in clinic this week with his creatinine to 200. That's about a couple of weeks after his initial methotrexate injury. So he will no longer have any further methotrexate, obviously, and will proceed to his maxillofacial radiotherapy instead. So thought that case was quite nice to highlight some of the potential other things that we need to think about in specific DLBCL cases, those with special sites of disease. His maxillofacial disease is in close proximity to the CNS, and also for these patients receiving high-dose methotrexate, just how easy it is, despite all of our best intentions, for these patients to go off very quickly. We have another gentleman at the moment who unfortunately is in intensive care, who developed AKI post-methotrexate, and so yeah, it can be not a very nice drug. So we do have to take lots of precautions and make sure we do all the things, fluid input, output, pH monitoring, adequate urinary alkalization, etc. So thank you, that's my presentation. I'll stop sharing, and does anybody have any questions?
Thanks, Tiana, that was great. And yeah, I agree. I thought it fitted really well with the prior presentations. I don't know whether, I can see Beth Phillips is still here, whether Beth can comment on whether there's any data as to how many, or whether what proportion of patients who receive high-dose methotrexate are able to complete all 3 cycles. And also, as Tiana said, the practice perhaps varies a bit across the country, and would you like to comment on that at all?
Yes, high-dose methotrexate is a hot potato, really. I'm afraid I wasn't there for the entirety of Adam's talk, so I'm not sure how much he covered high-dose methotrexate as prophylaxis. It's been CNS prophylaxis is something that's evolved in the last 10 years. There was a lot of intrathecal chemotherapy, but then there was concern that it doesn't cover the brain parenchyma adequately. So then there's been a wholesale shift to high-dose methotrexate, but no randomized trials to confirm its use, and a lot of retrospective data and comparison suggesting that it's beneficial in these patients, and suggesting perhaps in someone like this it might reduce the risk of CNS relapse from around 10% to around 5%, and which is significant because you can't treat CNS progression, although there are other retrospective data sets that have been released recently that contradict that, and there are lots of controversies in it. So for example, number of cycles, 2 versus 3, no one knows. Whether you give it all at the end of treatment or whether you give it in between cycles of R-CHOP. I think one thing that Tiana highlighted nicely is whichever way you do it, you need to give the CNS prophylaxis early, because CNS relapse tends to occur 6 to 12 months, within the first 6 to 12 months after initially starting treatment. So, delaying is futile really if you're going to give it. But it is toxic. In theory, the risk of severe CNS disease, severe renal toxicity with adequate hydration and urinary alkalization is only about 1 to 2%, from about 5 to 10% without. But we do see in these kind of older, slightly comorbid men who had some cardiovascular risk factors that there can be significant toxicity. So it is something that we can struggle to deliver in patients, and it needs very careful discussion of the risks and benefits with each patient. But it remains part of the guidelines, and albeit on shaky evidence, probably does reduce the risk of CNS progression.
Okay, thanks very much. So I think we're going to end the webinar now because we're bang on time, and that just leads me to thank our excellent speakers tonight, and Tiana for giving a really good case presentation. I think it's been a really great webinar, and I hope everyone has learned as much as I have.